Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner.
Hi, everybody. Welcome to Melanoma Matters. I'm Sapna Patel.
James Larkin, hi.
Hi, James. Let's talk NED today. I've heard people say immuned. I think a lot of us call it NED because it's the stage 4 NED trial. But before that, maybe just a few rapid fire questions. Did you have a job before going into medicine? Did you have a job like as a kid, teenager or anything?
Oh yeah, I've worked since I was about 9 or 10.
What was your first
I'm
job?
not kidding. So my dad had a fishing boat in the little village where we grew up, moored in the harbour. And so my first job was working as a deckhand on my dad's boat, literally from the age of probably 10 or something. So we used to have lobster pots and we used to trawl and all sorts of other stuff. And so, I was a deckhand on a fishing boat.
That's
which is
fascinating. And, fast forward 40 years, they make reality TV about that now, about deckhands.
Really? I didn't even know that.
Yeah.
But it's where I grew up had a tidal harbour, and the reason that's important is because you had to take your boat out of the harbour before the tide went out, and you couldn't come back again until the tide came in again. So that would mean that it was at least a 12-hour day in the summer.
Yeah.
So we would go out always before 6 a.m. and often get back after 6 p.m. as a small child in the summer holidays. And then go on.
No, you finished. Continue.
I know, and then I was just going to say when I kind of when I'd stopped doing that because it was very, very hard work and not well paid, shall we say. It's my father. Then I worked in shops, and I worked a lot as a waiter as well, actually, and I did odd jobs. I used to work at a hotel, and I used to be a waiter at breakfast in the morning, and then during the day I would sort of do odd jobs and actually barbecue, and then in the evenings I would do dinner. And I only stopped doing all that stuff when I was about 20 or 21.
Oh,
so
and the hotel's still in business? The reputation is still intact?
Yeah. Actually, the hotel used to be a school. I went to primary school there, my first school, and then it got closed as a school and made into a hotel. So yeah. I think it's still going. It's the little village I grew up in where my mother still lives now.
That's very nice. Well, I mean, it leads to many follow-up questions, but for another time. And this village, as we know, didn't have a street name, so you don't have a porn star name to go as a pseudonym.
Or at least not one that you approve of.
Yeah. Okay, so let's talk about the IMMUNED study published in Lancet. I'm just checking myself if it was Lancet or Lancet Oncology. It was The Lancet in October 2022 by Elizabeth Livingstone and our friend and colleague Dirk Schottendorf as the senior author. So, James, why don't you tell us about the IMMUNED trial?
Yeah, so I think an important study, academic study as well. So German cooperative group, randomized phase 2, and like you said, resected stage 4 melanoma with no evidence of disease, NED. So I think that's the title. And 3 arms, so placebo or nivolumab or nivolumab plus ipi, and the ipi dose here is 3 milligrams per kilogram every 3 weeks for 4 doses, followed by nivolumab maintenance, so the sort of metastatic dosing. So that's sort of a point of interest, I guess. And there was a year of treatment, and the primary endpoint was recurrence-free survival. So the total number of patients was sort of around about 170 or so sort of between 55 and 60 in each arm of the study. And when they reported it, there was about 4 years of follow-up. So relatively mature, I suppose. maybe one thing on study design is the whole question of placebo as a control arm in stage 4 NED. And I think the reason for that was at the time the study was designed and recruiting, Checkmate 238 hadn't reported. So anti-PD-1 monotherapy, i.e. nivolumab, hadn't been, let's say, established as a standard of care in stage 4 NED. So at the time the trial was done, I think it's fair that placebo is a reasonable control arm. I don't know if you'd give interferon in that situation in the US, or you might have done.
I mean, no, I don't. I don't. I think for stage 4 NED, we presume they're basically a metastatic, kindling there. But I find it interesting that it wasn't an IPI arm; it's a placebo arm. But I think that also speaks to your point about the time of when this was designed. That this isn't Checkmate 067 for stage 4 NED. This is a slightly different. Can we basically treat these patients as if they're in an adjuvant setting? And then what options do you have there?
Yeah, I think that's right. And the whole question of could there have been an IPI-10 control arm? We talked about that before when we talked about IPI-10 in the ORTC trial. I don't think people would have been sort of thinking about that. And I'm not sure it was really established as a standard of care anyway in stage 3 disease, palpable stage 3 disease at the time. So, I mean, I think I'm okay with the study design. I think, probably I would make the same comments that most people would make, which is a shame it wasn't a bigger study, because it's always, when you see randomized phase 2s with really actually quite strong signals, which this has, then you always slightly regret that there weren't more, but the benefit of hindsight's a wonderful thing, isn't it? So I think we have to.
Finding 175 of these patients anyway, just across Germany, that's pretty remarkable, I'd say.
No, I agree with that as well. I mean, stage 4 NED isn't really that common in the clinic, actually. So I think that in and of itself, recruiting the trial actually requires quite a lot of coherence as a group, I would say, as well. Everyone needs to be signed up and puts the patients in. So I think that's a decent achievement, I would say.
Yeah.
So maybe I should just say something about the efficacy. I mean, the curves, I'm just looking at the Lancet paper now, I think in many ways speak for themselves. And I'm just looking at the curves. This is figure 1A, and
they're so
placebo's
big,
gone.
The curves are the gaps are so big. The authors were able to put their text in between the curves, as you see in figure 1A. So it wasn't that they sat it above the curves or below. It was like in between the curves, they put their text.
So yeah, what hazard ratio do you think you need so that you can fit text between curves? That's an interesting question, isn't it? And
that's a hard question, I think.
There's probably some sort of correlation between hazard ratio and font size, if you see what I mean. But they didn't cheat on font size, I don't think, either, because that's an obvious way that you could do it. But anyway, so if you look at the comparisons for ipi-nivo versus placebo, hazard ratio 0.25.
Incredible.
This is about 4 years of follow-up. Yeah, absolutely. And you don't really see those kinds of hazard ratios very often. Confidence intervals worth commenting on, though, on that is 0.13 to 0.48. So it's quite broad, but nevertheless clearly a difference, which you would have predicted, I think. And then if you look at the nivolumab in blue versus placebo, hazard ratio is still 0.6, and that hazard ratio is touching 1 on the confidence interval, so 0.36 to 1. And then, you can make a comparison between Nivo and ipi-nivo, which is the bottom one, which actually is 0.41. And maybe for me, I suppose, with non-unity overlapping confidence intervals, I suppose looking at this, that's the biggest surprise for me, actually, the difference between the Nivo and the ipi-nivo.
I mean, correct me if I'm wrong, though. I'm a little surprised Lancet let this in. This was not a pre-designed endpoint to compare to Nivo-Ipi to Nivo. It was always powered to compare to placebo, similar to Checkmate 067. And so this would be considered exploratory. They're highly underpowered to do this. It's lovely it came out with such a strong hazard ratio. But when you're underpowered to do it, I'm a little surprised Lancet let them in with this kind of exploratory. But your point is exactly, I think, as we all interpret it, which is, well, that it's hard to deny that the and maybe this goes again to putting the text in between the curves. The gap between those two curves is the largest too, so it's fair. It's I guess it's larger than Nivo and placebo, so it's fair to talk about it, but with the caveat that they were not designed to do this analysis.
Yeah, I think that's right. And, as far as I'm concerned, they got it into the Lancet, so congratulations to them. It's a randomized phase 2 trial. People talk about it.
Yeah. And I
Just
guess,
maybe.
wouldn't you say now you have a patient in clinic come and they've had oligometastatic disease, your surgical team's been able to remove them, best that you can tell postoperatively or with scans, they have no evidence of disease. Is there even a role for placebo or observation after a study like this?
No, I don't think so. But I mean, I'm not sure there was ever really, for me anyway,
You could
a
get
role for
reimbursed.
observation.
You could get reimbursed for the.
Yeah, so our reimbursement situation sort of has followed the registrational trials, meaning that as soon as Checkmate 238 came out and got it reimbursed, we can use anti-PD-1 monotherapy nivolumab for stage 4 NED. But no, we don't have reimbursement for ipi-nivo for stage 4 NED. And again, some of that might come back to the fact that this was an academic randomized phase 2 trial, which done obviously without registrational intent. But what I was going to say is that I'd always been very nervous anyway about observing this group of patients because, it comes back to tempo yet again, doesn't it? There will be some patients where you really have a long natural history. And, my question would always be, and maybe not for now, how do you actually define the word oligometastatic? Do we have an agreed definition of that term? I'm not sure we really do. People use it all the time. But anyway, the point, I suppose, is that if you've really got someone with a very long natural history and they've just really had disease that can be controlled surgically, then okay, maybe you're okay to keep observing them. But that's not that common. Actually, most people are going to be developing overt metastatic disease on their next scan. And my sort of comment on loco-regional treatment is, because this is what we're getting into now, is that it doesn't change the natural history of the disease. The only thing that changes the natural history of the disease is effective systemic treatment. And so I'm always kind of fairly anxious, and always have been, to give people systemic treatment and then reserve loco-regional treatment, actually. So it's almost the other way around. For sites of oligo progression, again, I'd make the same comments about the definition of that term. And those patients who've had checkpoint inhibitors, actually, no matter what the regimen is, and you're just doing surgery or radiotherapy for 1 or 2 sites of disease, actually do very well. But that's kind of not
maybe we could
not exactly relevant to this.
Yeah, maybe we could put a pin in that, because I want to circle back to that at the end with maybe just how you're using this study in the clinic. So what do you make of these forest plots? Were there any subgroups to you that really show a strong signal here? One of the things we've seen dissected as exploratory in 067, I think you can find it for 047, but maybe not published. Maybe it's been presented. And we saw it here with IMMUNED. It was like the BRAF subgroups. Do you find anything interesting with BRAF, NRAS? Any of these subgroups make some waves for you, or this is just sort of across the board, stage 4 NED, some systemic checkpoint inhibitor?
Yeah, so I mean, I think on the subgroups, extreme caution is necessary in this trial. If you look at the numbers, and you can see that anyway from the widths of the confidence intervals. So I'm looking at figure 2A now, which is RFS, DFS. I think the thing that I would pick out probably is BRAF status, which the authors comment on, and we, as you imply, we talk about quite a lot. So the hazard ratio there favouring ipi-nivo is 0.1 or thereabouts for BRAF mutant versus placebo. for 0.4 for BRAF wild type. So quite striking, despite those caveats. Everything else, I don't really think so. Looking at them, and I would maybe just pull out previous radiotherapy as well. Excuse me. A hazard ratio of 0.12, but really tiny group of patients. And neither of those things, if you go in the bottom part of the funnel, which is nivolumab versus placebo, are really jumping out in the same way.
So anything else you want to point out on this forest plot here?
No, I mean, I think that the main thing is that the BRAF is consistent with what we saw in Checkmate 67. In other words, the bottom line there is that ipi-nivo seems to differentially perform better in BRAF mutant melanoma than anti-PD-1 monotherapy, and that observation's been made a lot in Checkmate 67, for example. I'm still not really sure that we understand it. If we're talking about PFS or response rate or recurrence-free survival or something like that, I mean, I think the slight footnote there is if you're talking about overall survival, it might be a little bit different, but I think, because that's confounded by what happens afterwards. But I'm not sure we understand it, but it seems consistent across studies, is what I would say.
So you're not ready to call BRAF a predictive biomarker for response to certain immunotherapies?
No, I don't think anywhere close. I mean, I think it's just a factor you might think about, like a lot of other factors we might think about in certain situations. And then, I'm still really intrigued by radiotherapy, and I don't think this is anywhere near bottomed out, actually. And the numbers are small here, but I wonder for a long time now if there's an interaction between radiotherapy and checkpoint inhibitors, and whether that's single agent or combination. And this is actually complex because there's radiotherapy and radiotherapy apart from anything else. And actually, a while ago, I don't know if I've ever talked to you about this, Paul Nathan and I tried to do an academic study of ablative radiotherapy, so sort of 24 gray in 3 fractions, plus anti-PD-1 versus anti-PD-1 alone. And I can't remember what the efficacy readout was for the study, randomized phase 2 academic trial in the UK, to try and get a little bit of traction on this question of whether ablative radiotherapy might improve the efficacy of checkpoint inhibition, but we couldn't recruit the study. And we had, which is a real shame, because I think the question still stands. And I think that, that there's a big question about the dose of radiotherapy, the fractionation, and so on and so forth. And I think we will get there.
I think we need to have a planning session at Paul's farmhouse in the north of Spain, and really, with a lot of good Rioja, figure this out. Just get a whiteboard there, a chalkboard, lots of red line, and just plan this out. We'll figure out how to do a cooperative group study. And
does Paul really have a farmhouse, though? Are you certain about that part?
I don't know that it's a farmhouse. I was just trying to be quaint about it. I'm sure it's a beautiful home. It could be a seaside home. It could be a
yeah, and the other kind of, I mean, that sounds great, obviously, don't but the other thing I've often wondered about is toxicity as well, on this exact same question. About whether there's a difference in toxicity for checkpoint inhibitors if you've given someone ablative radiotherapy along the way. And anecdotally in clinic over the years, I've often thought, that someone had a toxicity I kind of wasn't really expecting, and they just had ablative radiotherapy. But of course, then it's all about causation, and then you need to have good numbers to try and work out what's going on. And I don't think we really have any good data on that.
We tend to have disagreements, between our radiotherapists and our medical oncologist over which is the leading toxicity. Somebody will get vertebral ablative radiation and then develop some esophagitis. And, we tend to disagree. Was it the ablative dose of radiation that certainly linearly pierced the body and might have had some scatter effect? The radiotherapist would say, no, your therapy is more likely to cause esophagitis, and so on and so forth. So I think that will always be a difficult one to tease out. But to your radiotherapy point, when I look at this forest plot, there's about 29 patients who had previous radiotherapy that received either Nivo, Ipi, or placebo, and then an additional, I don't know how many are on the Nivo alone, but I guess the point is, you know, in those small numbers, there's so many questions to find out, which is what was the site that radiotherapy was done to? Like you said, the doses. What was the lead time before receiving your checkpoint? Was it, you know, 6 months prior, 6 weeks prior? We have to presume there's some overlap between radiation and checkpoint inhibitor that occurs when you do it concurrently, or obviously concurrently, or even close sequentially. But what was it here? And so all those things, I think it's an interesting signal, like you're saying. And I guess if we're really clarifying, it's radiotherapy that gave them this NED status. So it's a bone metastasis, presumably a brain metastasis, or some other site. It's probably not a lymph node or a liver or a lung, where we would more traditionally resect those. So it's a site where it was the radiotherapy that made them NED. You know, are we mopping up extra disease with the checkpoint, which is what we think we're doing in this patient population anyway. So, but let me maybe ask you a couple of scenarios for clinic use. So now you're in the UK. I guess you've never been anywhere else. You're there, and you've got a study like IMMUNED. You've got regulatory approval for Nivo in this quote unquote adjuvant setting. You've got regulatory approval for Ipi-Nivo, or as the company would want us to call it, Nivo-Ipi, emphasizing that the Nivo is infused first before the Ipi, for stage 4 disease. What algorithm do you use for a stage 4 NED? Do you go down the stage 4 and try to get Nivo-Ipi approved for them? Do you go down the adjuvant and try to get Nivo approved for them?
Yeah, well, so my take-home message here, I think, is that anti-PD-1 monotherapy is probably under treatment for stage 4 NED. So that's my headline. That's where I start.
Okay.
We don't really have any flexibility for reimbursement, is the honest answer. So, you know, you can follow the patients out to 3 months because it's adjuvant. And then some of them actually will have developed over small volume disease. So then you can treat them with ipi/nivo. But if you've got someone, for better or worse, and you follow them out to 3 months afterwards, and there's still no other disease, then you have the choice between treating them with anti-PD-1 monotherapy, nivolumab, as per CheckMate 238, or you sit tight and watch. And that's
what you do.
I was going to say that's the way it is. And so no, all I was going to say is, and then I have that discussion with the patients.
Yeah.
If you see what I mean. And if I'm completely honest, if there's any scope for blurring the boundaries a tiny bit here, you know, so for example, in the brain might be an example of this, where, you know, the scans are, let's say, you know, you do the scans afterwards and it's not entirely clear whether, you know, whether it's scarring or not. And then I would tend to say, well, actually, that's probably a bit of residual melanoma. We should treat you with ipi/nivo type of thing.
Yeah.
And some parts of the body you can do that, other parts you can't. But so it's frustrating, I think, is the answer.
First of all, I think if we didn't have video, we would be talking over each other so much more, given our 7-hour time difference and bandwidth delays here. So the theme that emerges for me, as we've done now so many of these episodes, is tempo. Your real instinct when you see a melanoma patient is you try to get a gestalt of what their tempo is. And if there's a little bit of uncertainty and we don't know what somebody's tempo is, you give it a little bit of tincture of time, to just, because their tempo will declare themselves. If it's rapid, it will declare it. And if it's not so rapid, you'll, you know, be. So maybe we will end up having a subtitle to this podcast: Melanoma (tempo matters), because I like that thinking. That's actually often what I think of when it comes to a mucosal patient. A stage 4 NED is, I can rush and do something now, but if I'm limited by what I have access to now, and I will have more access, you know, if you actually develop metastatic disease, I do a little bit of time and tempo test for them. So I like that.
Yeah, and I mean, I think I was just going to say the other two bits to that are the toxicity, and so then let's say you're using ipi/nivo at these doses, metastatic doses, with someone who's got no disease at all on their scan, and tempo-wise, you're thinking, well, actually, they might not develop any for a while, and then they get bad side effects. Then I naturally feel bad about that.
Yeah.
So I think that's one thing to say. And I think the other thing about this tempo discussion, I think the most difficult part of it is how you counsel the patients about how you're thinking about this, because a lot of people come into my clinic, they want treatment tomorrow. And I
Sure.
think that's the natural human instinct in this situation. And sometimes I see patients, who other people have seen already, and no one's really kind of sat down with the patient for sufficiently long to really talk all this stuff through. Because I think it's very easy if you're a patient, I must have treatment. But
Sure.
actually, they don't know generally what the side effects are, and we do. So I think that's what I'd really flag. You need to spend some time with the patients, talking to them about this right at the start, so they really understand
Absolutely.
how
And
you're
there
thinking.
are other examples in medicine, where we do tincture of time or lifestyle modifications. Not that we would be telling our patients that's what necessarily they have to do at this moment, but there are examples for diabetes, pre-diabetes, cholesterol management, things like that, where you would say you don't necessarily jump them on to treatment, the first or second time you find this. You sort of say, okay, now that you know this, let's see how. Anyway, I guess there's some model for discussing this with a patient, theoretically. One other question, maybe scenario I want to pose to you, and it was your example that you were giving, a patient's on checkpoint inhibitor, and they're doing quite well, except for one sort of lingering, or however we're defining oligo disease. So there's some oligo disease lingering. You then address that with local regional therapy, radiation or surgery, or some sort of ablative measure. And what then? You have had them presumably, on some sort of maintenance therapy, though now you could argue your maintenance could have been, nivolumab or relatlimab. But if you have them on some maintenance PD-1 or PD-1 lag 3, you then address the oligometastatic sites. What is your thinking now when you see that patient in clinic? Is it to go back to my maintenance that I was maintaining them on? Because again, tempo has shown me that these chronic ones are not progressing. I can address them at leisure. Or is it would you kind of want to ablate them, wait 3 months off therapy, image them, and if they've developed new distant disease, then you can reach for combination? Or how do you think about a patient you?
Yeah, well, again, as ever, we're somewhat constrained by reimbursement. In other words, we can't really take patients on and off treatment easily anyway. If you stop the treatment, generally you don't get it back. Nevertheless, I would, with those patients, continue my maintenance treatment. To be honest, even if you stopped it for checkpoint inhibitors, 3 months isn't that long if you think about how long the drugs, are on board.
Yeah.
So I would normally carry on, and I think, we actually published a retrospective single institution series on exactly this question. Francesca Comito was one of our fellows at the time. This is 2 or 3 years ago. So all we did basically was we took all the patients that we treated with checkpoint inhibitors who generally had benefited on the first scan. They'd gone on to maintenance treatment, and then they'd had a site of progression that could be dealt with surgically or with radiotherapy, or maybe 2 max or something like that. So it's a highly selected group of patients. And then we went after whatever the oligoprogressives, and I'm not suggesting, by the way, that my definition or this definition of oligoprogression is the correct one, but I'm not sure what the correct one is either. Anyway, so then we dealt with whatever that site was, or sites, 1 or 2, carried on the maintenance treatment, probably stopped them at 2 years, other things being equal, because that's what we do. And then the outcomes in terms of OS with 4 or 5 years follow-up for those patients were just exactly as good as the ones who hadn't had quote-unquote oligoprogression, which is what I kind of noticed in clinic as well, actually, that these patients can really do quite well. There's millions of caveats here, obviously, single institution, retrospective bias, blah, blah, blah. But nevertheless, I actually, it's a good project for a fellow. I said, look, we should just get this out so that people can see. And actually, to some extent, that people are, when it's appropriate, aggressive in managing oligoprogressive disease and not nihilistic, because sometimes you see that, they've progressed, So actually, hang on, that otherwise they've responded really well, and we can deal with this with surgery or radiotherapy. So that'd be another message, I think. Comito, Comito, Francesca is the lead author. Can't remember the journal.
I think we thought we didn't have enough to talk about with ImmuneD, but it turns out there's a lot. I have even more patient cases that maybe I'll ask you about. And frankly, if it makes it into this episode, we'll keep it. Otherwise, we'll slice it out for another. Let's say you've given somebody 2 years worth, and I guess there's two scenarios. One is they're a complete response. You stop the therapy because you've given them the prescribed course. And in short term, 6 months or a year, now oligometastatic disease, however James Larkin defines it, has come back. What then? Are we treating that and then following, with adjuvant? Are we keeping it in place, calling it quote unquote perioperative? Are we just calling them metastatic or success? This goes to your tempo thing, which is why I say it's not immediately after you stop the 2 years, but it's maybe a year later. What are you doing for those patients?
I don't think there's a one size fits all there. I really don't.
I agree.
I mean, first and foremost, you know, if you've got oligo progression, you deal with it with a local regional treatment, and in a way that's the easy bit. I think the difficult bit is thinking, well, actually, should we try and do some more treatment now? And you don't know the answer to this, obviously, because the answer will only be manifested on subsequent scans. Or do you say, well, actually, this was a sanctuary site the whole time, we've now dealt with it, the rest of the disease is gone, actually maybe the patient doesn't need any more treatment? So I don't think there's any kind of easy answer here at all.
And with caution,
again,
this shows up on board exams sometimes, to some degree, without naming the boarding agency. Sometimes this will show up, you've got oligometastatic disease. Is your approach systemic therapy or local regional? Well, that's a fucking controversial question. Why is that showing up on a board exam? There's no data for this,
Yeah, well, I guess the use of the word fucking will probably mean it doesn't get into the podcast. No, that's ridiculous, isn't it? Because a board exam is what level of competency? Sort of like an adequate level of competency, but not expertise. Is that right?
No, I mean, this is basically to say these are the sort of established standards, right? I think we give board exams in the US or globally so that people know what the established best practice or best level of evidence is, so people aren't running around doing malpractice. So to ask a question like that on a board exam, as if there was a correct right and wrong and a defensible and a legally proper, no, there isn't.
No, I mean, yeah.
The answer apparently was local regional therapy. Resect the lung metastasis, observe. And, that's controversial. There would be many an oncologist who would say, oh, I call that metastatic disease. I'm treating that. Or that to me is a sign of micro. Even if I resected it, I now know it's, just a setup for micro. Anyway, it's controversial.
Yeah, but I mean, whoever set that question doesn't know what they're talking about.
Yeah,
Because
exactly.
if they did, they wouldn't set it. I mean, and I think the standards of care here myself are probably being treated in a unit where you're actually doing this a lot, where you've got surgeons, you've got radiation oncologists, you've got medical oncologists, you've got the whole team as well to support the patient.
Yeah.
And you make a decision together. And
yeah.
And this might always be beyond the realms of randomized trials and good evidence. It's just like, we've done this a lot before. And our sense is that these are reasonable options, and that something else might not be a reasonable option. I'm not even sure you can take it far beyond that.
I think you're definitely right, because ultimately the personalization that it comes down to is how well they tolerated a previous surgery, previous checkpoint, this whole tempo thing, what it means to their quality of life to have a one-time surgery and done and observe if we think their tempo is pretty slow versus continuous interaction in their life with systemic therapy. Anyway, okay. So back to, we actually really did have a lot to say on this stage 4.
Surprising, isn't it?
Yeah. Good that we have some level of evidence now in this study or in this area, because I think it helps us. So I guess the bottom line, you've already given us your headline, which is you think PD-1 monotherapy is under treatment for this group of patients with stage 4 NED. Yet globally, we know people will be encumbered by reimbursement issues. So despite that, you may not have access to combination. No easy answers here, but tempo matters. And maybe if you have one of these stage 4 NED patients, you're in this adjuvant setting, give it that sort of 84-day, 3-month window to your next scan and see if you can get a sense of their tempo, and then sit down and make a determination on what to do.
Yeah, absolutely.
Good. Okay. Well, thanks for the discussion on this study.
Thank you.